Hello everyone, we are going to start with hip fractures, ortho surgeries and amputation. Let us start with the predisposing factors of hip fracture. Elderly are more prone to this, and they are more prone to have osteoporosis, altered orientation, neurologic deficits. They may have environment changes like some may be staying at home, some may be staying in a assisted living facility or a nursing home. So those kind of changes can affect, and the medications they are on too. Hip fractures are mainly of two types. They are intracapsular fractures and extracapsular fractures. The intracapsular fractures are associated with osteoporosis and minor traumas. You can see the pictures here. They are subcapital fractures, which happens below the head of the femur. Transcervical is the fracture across the neck of the femur, and basilar neck fracture are above the trochanters. The extracapsular fractures are usually associated with severe direct trauma or falls. When the patient is falling, elderly patient with unsteady gait and all that, when they fall down, this type of fractures can happen. The most common extracapsular fractures are intertrochanteric fracture and subtrochanteric fractures. Let us look at what are the signs and symptoms. The patient will have severe pain at the fracture site, like in any fracture, inability to move the legs, and there could be shortening and external rotation of the affected leg. You can see the picture here. Possible swelling and ecchymosis. It could be ecchymosis could be a later sign. So what are the pre-op management? We need to maintain the anatomical position and place the patient on unaffected side. We need to keep a pillow between the knees so that we can slightly abduct the extremities and keep a pillow underneath the lower legs so that heels can be off the mattress, because a lot of time the patients may have, like, when they keep it for a prolonged time, we don't want them to develop any pressure ulcers on the heels. And possible buccal traction, we have learned about the tractions in the previous class. Skin care, meticulous skin care, and pain management. So the preoperative management always include, if at all possible, we need to teach them deep breathing and coughing exercises and ask them to demonstrate it. The same thing with use of incending spirometer too. And the cough pumping exercises, remember we learned about those exercises in the pre-op and post-op, those classes. And we also need to use narcotic analgesics for pain management, because the pain could be very severe for this patient. Other diagnostic measures you will see, like in any other surgeries, you want to have an ECG done for this patient, radiography, the hip AP and lateral x-rays, the anteroposterior and the lateral view of the hip need to be done, and the chest x-ray, the posterior anterior chest x-ray and the lateral view need to be done. In the labs, as usual, CBC, electrolytes, type and cross match need to be done. So what are the goals of the surgery? This is to reduce and stabilize the fracture. We need to increase the mobility of the patient, we need to decrease the pain, and prevent further complications. Those are the goals of our surgery. The most common type of repair you will see is the open reduction and internal fixation, otherwise, in short form ORIF. So how this is done is you will secure the femur in place with pins, screws, nails, or plates. And the ORIF is done in intertrochanteric fractures and subtrochanteric fractures. The two types of repairs are hemiarthroplasty and total hip arthroplasty. The hemiarthroplasty is the replacement of femoral head with the prosthesis, or the replacement of acetabulum with the prosthesis, and also the femoral neck can be replaced in this. So the total hip arthroplasty, you are replacing the femoral head as well as the acetabulum with the prosthesis, and also you are replacing the femoral neck. The post-op management nursing responsibilities, these are very important. We'll be repeating this again and again. Pain management, positioning, you need to make sure that there is no adduction or high Fowler's position is done. And you keep a pillow between the legs so that you can maintain slight abduction. And ROM of the unaffected limbs need to be done, application of the eyes. Activities you need to advance as tolerated. Weight bearing as per the doctor's order. In case of an open reduction and internal fixation, full weight bearing may be delayed up to 6 months. So in case of a hemiarthroplasty or total hip arthroplasty, often full weight bearing is possible once the patients stop limping. These are some of the pictures showing that what is a no. Look at the first picture. Do not bend down your operated hip beyond 90-degree angle. Do not cross your operated leg or ankle. Do not turn your operated leg inward. You see both the lying down positions. The first one is a no because it is internally rotated. You need to keep a pillow between the legs. Look at that yes sign. Hip precautions. This slide is very important. You need to know this. This is also available in chapter 18, page 312. Look at the box, chart 18.3. And so the hip precautions you want to maintain for at least 12 weeks. So remember, avoid adduction of the operative leg. Do not cross legs over midline of the body. Use abductor pillow. Do not sit or stand for a prolonged period. Know your weight bearing status. Keep leg and hips in proper alignment. So always remember that you should not bend the hips more than 60 to 90 degree, especially if you had a posterior surgical approach. They should not bend the hips more than 90 degrees. You need to have elevated toilet seats. And when the patient is first up, make sure that the legs are kept extended, well supported, and elevated. Let us look at the nursing process or the nursing diagnosis. Number one is always acute pain, impaired physical mobility, right? And impaired skin integrity, risk for impaired urinary elimination, right? So these patients may have risk for impaired urinary elimination because they are not ambulating well, and immediate post-op period they may have urinary catheters too, and of course this has to be removed as soon as possible. They may have disturbed thought process. The collaborative problems like a risk for peripheral neurovascular dysfunction, hemorrhage, deep vein thrombosis, pulmonary embolism, pressure ulcers, pulmonary complications, and non-union. So these complications are available to read table 18 to page number 311 of your EKG textbook. The post-op confusion is a fairly common issue. The patient has unfamiliar environment because they're staying in a hospital and later they're going to a rehab. It is different from their home setting. They may have alteration in sensory input, loss of control, and control of an uncertain future because they don't know what can happen, where they're going after surgery, may or may not go home, they may go to a rehab facility. So they have a disruption of their life pattern. They have immobility and pain. Just because of their immobile itself, they may have more pain once they start moving around. So they may tend to stay immobile due to that pain too. Disrupted pattern of elimination is possible. They could have constipation, urinary elimination pattern also can be disturbed. Now we are going to look at orthopedic surgeries. The most common orthopedic surgery is the total joint arthroplasty. The arthroplasty can be usually done on the hip as well as it is done on the knee. So the goals of total hip or knee replacement is to relieve pain, provide motion with stability, and correct the deformity. Are there any contraindications for arthroplasty? Yes. Poor general health, severe osteoporosis, those conditions you won't do this arthroplasties. And infection, a systemic infection or a local infection are absolute contraindications for arthroplasties. What do we need to do preoperatively? We need to complete a history and physical examination. We need to evaluate the muscle strength, stability of the ligaments and the range of motion, radiographs of the hip and the knee, chest x-ray, like we had discussed before, posterior, anterior and the lateral views, and EKG, CBC, chemical profile like a Pro8 or metabolic profile, and the clotting studies, typing and cross-matching. The pre-op teaching should include information about the surgery, deep breathing and coughing exercises, instant spirometry. We keep repeating this again and again throughout our course, I believe. Explain activity restrictions, teach use of overhead trapeze, which they will be using post-operatively when they wanted to sit up and if they want to move from the bed. Muscle strengthening exercises, post-op pain control, pre-op and pre-op skin preparations, and antibiotic use, lifetime prophylactic antibiotics. If they are using prosthesis, some of the surgeries they may require to use lifetime prophylactic antibiotics. The post-op responsibilities are check vital signs, neurovascular assessment, monitor incision and bleeding, reinforce dressing, PRN, check the IV size, proper positioning, make sure that no adduction is done, no internal rotation is done. Deep breathing and coughing exercises, we need to encourage them to do it very often. And the pain management is very important. You need to assist the patient out of bed as soon as possible, usually within 24 to 48 hours. So and at that time you should also reinforce that there is restricted weight bearing, initiate physical therapy and exercises. You need to give good incision care and dressing as required. So the incision care, you need to follow the instructions provided regarding the dressing changes. Some surgeons may use specialty dressings that do not need to be changed, and so no dressings may be needed if a skin sealant was used. So you should always inspect your hip incision every day for redness, heat, or drainage. And if any of these are present, call your surgeon immediately. You need to teach all this to the patients. So also you need to teach the patient that when they go home, they should not bathe the incision or apply anything directly to the incision unless they are instructed to do so. So in the total hip replacement, always remember, prevent hip flexion of more than 90 degree, especially with posterior surgical approach patients, and with patients with anterior surgical approach, you do not hyperextend your operative leg behind you. That is, do not hyperextend your operative leg behind you. So, and also we need to tell them to prevent lying on their operative side, and do not use they do need to use elevated toilet seats. So you need to assess for prosthesis dislocation. How do you assess? Assess for increased pain. Do they have a popping sensation? Do they have inability to move the lower extremities? Those are the signs of prosthesis dislocation. And you must have seen the CPM machines, that the continuous passive range of motion device is used in hospitals like Putnam and Mid-Hudson. I have seen at some point I have seen many patients were using this one, and then I wasn't seeing many of the CPM machines being used. It is all depending upon the surgeon's preference, as well as the the cost effectiveness too. You need to encourage high fiber and high protein diet, reinforce discharge exercises and activity restrictions. Always remember to tell them that do not twist their body when standing. Use prescribed ambulatory and ambulatory aids such as walkers when walking, assistive devices as you use assistive devices as they need, and do not put weight more than what is allowed on their affected leg. Those are the important instructions you need to tell them. And also they can use ice as needed to prevent swelling and minimize pain. The post-op complications are the most common is DVT and pulmonary embolism. Infection, it can lead to removal of prosthesis. It can be, you may see patients complaining of dull pain. Then you need to be carefully evaluating them. Dislocation is possible due to excessive activity and due to different bone pathology. And hemorrhage is another complication, and neurovascular compromise. The total knee replacement, that's another thing I want to tell you, is that with all advanced technology, years ago they only had the standard knee replacement for the total knee replacement. Now they have this 3D technology. So what they do is that they go the 3D X-rays, and they make the 3D the prosthesis which is the exact fitting of that patient, the measurement, everything is the exact perfect fitting. So the advantage of those 3D replacement is those patients will have early recovery compared to the patients with the standard knee replacement. It's all the beauty of advanced technologies now. So for these patients, total knee replacement patients will need to go on CPM machines and knee immobilizers. We need to maintain the intake and output, encourage high fiber, high protein diet, reinforce post-discharge exercises and activity restrictions, and prophylactic antibiotics. For pain control, epidural analgesia can be used. I'm not going to discuss more on this. We have discussed about epidural analgesia in the previous classes. For pain control, we can do the femoral nerve blockade. So here a catheter is inserted along the femoral nerve using a nerve stimulator needle. And so if the patient has a femoral nerve blockade, the patient needs assistance with ambulating. So what are the discharge instructions for total knee replacement? We need to teach them the signs and symptoms of infection, knee exercises, because it is important when they go home, they continue. Some patients may go to a rehab, and when they go home, there is a possibility of having home care physical therapist come and do the exercises till they can go to a PT office and start doing the exercises. And also, they will be teaching them, and their patients need to continue all those exercises at home. And safety in home, no clutters, say, like reduce the fall risk at home. Positioning is important. We are moving on to amputation. It is what is amputation? It is the partial or total removal of a body part, and this event is devastating to a person. Some of the statistics about amputation are there are nearly 2 million people living with limb loss in the United States, and among those living with limb loss, the main causes are vascular disease, that's 54% of them, including diabetes and peripheral arterial diseases. Trauma is 45% and cancer is less than 2%. So the most common cause is the vascular diseases. And approximately 185,000 amputations occur in the United States every year. That's a huge number, right? So if the body part is amputated, like in a trauma or an accident or in a machines, reimplantation is possible, but it depends upon which body part was amputated, how well it was preserved, and the extent of disability associated with loss, and patients with other injuries, and all of the overall health. So remember, I don't know if you remember what I said about a child who lost all his fingers in a shredding machine. We were unable to preserve them because there was so much damage to the lost parts. But in some cases, you are able to preserve that part, and then, with a good plastic surgeon and in a tertiary hospital, they are able to reimplant it. Again, it depends upon the extent of the damage and how well it was preserved. So we should always, people say that, if accidentally a finger is cut, is amputated, you need to put it in ice immediately and go with that to the nearest tertiary hospital. So if your patient is going to surgical amputation, your pre-op responsibilities include checking the physical condition of the patient, level of amputation, check the peripheral vascular function test, patient's attitude, rehab potential, like how it is going to be, where the patient is going to be, what kind of prosthetic devices he will be using, all that. The types of amputation, two types, guillotine and closed. In guillotine amputation, this is a surgery performed without closure of the skin in an urgent setting. Usually the indication is a catastrophic trauma or an infection control measure, of an infected gangrene or something. So it is like kept open. And the other one is closed flap. You are after the amputation is done, it is closed with the flap and it is closed with the skin. So I have seen both of them. Both of them are really devastating to a patient, no matter what it is. I forgot to tell you about, I was going to say about the child safety. This is something which we always remember, pediatric population. A lot of children get into accidents, like accidentally cutting their fingers, like I said, shredding machine. Another one which couple of years ago I have seen is that somebody was mowing a lawn, and this child was in front of the mowing machine, and the child's legs caught in between and basically got amputated. It was very, difficult to handle it, and it was very sad to observe, watch what the child is going through. So these are the safety measures people don't think of what can happen. So, whenever people are operating such machines like a snow blower or a lawn mower or something, we should not have children near them. These are some of the pictures of amputation. The pre-op preparation also they need routine pre-op preparation and strengthening exercise to prepare for change in balance and crutch walking. These are the things which we can prepare, like a surgical amputation, and if the patient is diabetic and we anticipate that, we can train them. In emergencies, of course, we don't have any control over it and we cannot do anything. But other situations like elective surgeries, we can always teach them the strengthening exercises and how to use crutch walking. They can meet with an orthotist so that what processes what they're going to use and get familiar with that. And also they're going to live in the rest of their life with processes, and they may have other chronic conditions too. So management of chronic conditions like peripheral vascular diseases, diabetes mellitus, and some may have the amputation due to cancers. So those patients may need to continue their chemotherapy and other medications and other modalities. So they need to be prepared for that. The post-op goals for amputation is promote healing, prevent any complications, assist the patient to cope effectively. They have the body image, return the patient to maximum mobility as soon as possible. And one of the complications of amputation is the phantom pain. The patients feel pain on their lost part of the extremity. and the patients need to be aware of that. And for some patients, if it is an accidental one, when they wake up, they don't see um, the rest of the extremity or the body part. It is a shock for them. The postoperative care also include, you know, individualized based on the reason for amputation, um, like check for edema, bleeding, assess the wound healing, assess the patient's psychological aspects, and shaping of the residual limb. This is done, like a rigid or compression dressing, so that they can shape the residual limb, the remaining part, so that it can fit to a prosthesis in the future. So you probably must have heard about IPOP. That is, IPOP is the immediate post-operative prosthesis. Immediate post-operative prosthesis. So this is also placed for patients on their residual limb, so that they can shape it to fit into a prosthesis in the future. And positioning of the patient is important. You need to take care of the pain of the patient too. So the prosthetic fittings, you can use rigid dressings that if for immediate measures, you can use rigid dressing, and this rigid dressings will decrease the edema. And also we are preparing this patient for early weight bearing. And this type of rigid dressings decreases edema as well as it protects and shapes the limb. And also, you can apply it and remove it and inspect the wound for any signs of infection too. And as a delayed measure, later stages, you may use an ACE wrap. This is the picture of how do you wrap a residual limb. The first row is how do you apply bandage of a residual limb on above knee amputation. And the second row pictures are how do you wrap a below knee amputation residual limb. So how do you care the residual limb? Wash daily with soap and water, keep it clean, dry. Do not use oils or creams on the residual limb. Perform conditioning, toughening exercises. They need to have a muscle strengthening. They need to do that because in the future when they are using the prosthesis, they need to have that strength. Observe condition of the residual limb daily and wrap firmly day and night. And you can use a stump stringer or stump sock in order to, this is also helpful in shaping the residual limb. So the choosing of prosthesis is based on the occupation agility, which is the ability to move quickly and easily, and general health of the patient and motivation of the patient. These are some pictures of people with prosthesis, and look at the right hand side picture. Remember the Blade Runner who was in the 2012 Olympics, which was held in London, and he participated in the 400 meters race. think his name was Oscar Pistorius, and this was very interesting to see how he progressed and how he was determined to participate in the Olympics. So it is all people's motivation and determination, and they can achieve anything what they want. That's all about amputation. Thank you.